Assalamu alaikum wa rahmatullah. How are you, everyone? Welcome to the Zoom meeting. Today, we're going to talk about different topics, and I'll give it to Dr. Osama when he's available to start. How are you, everyone? Welcome to the Zoom meeting. Today, we're going to talk about that. So, Dr. Osama, when you're ready.
Yeah.
Thank you.
Okay, our first presentation will be nutrition and dehydration in elderly, and this topic will be presented by Dr. Monia. Dr. Monia, if you are here, you can go ahead and start.
Yes, assalamu alaikum and good afternoon, everyone. My name is Monia Alhadad, and can you hear me?
Yes.
All right, so today I'm going to present a very important topic that we should all be aware of, which is the nutrition and hydration in the geriatric population. So I'll share my screen. All right, please let me know if you can see the share.
Yes, we are.
Okay. All right. So as we said, our topic will be about nutrition and hydration in elderly adults. We'll be covering so many topics related to that. Let's start then. So at the end of this presentation, we should be able to describe age-related changes in nutritional health and how to screen for and assess nutritional status, nutritional syndromes common in older adults, nutritional interventions for undernutrition, cultural factors that influence nutritional care, and last but not least, legal and ethical issues related to nutrition. These are the topics that will be covered as age-related changes, nutrition screening and assessment, and nutritional syndromes. We have two syndromes, undernutrition and obesity, and the interventions that we can make to keep these people healthy as much as we can, and culturally appropriate nutritional care and legal and ethical issues. So let's start first. We'll start with the topic of nutritional changes in the elderly. So we have like 4 or 5 elements: body composition, energy requirements, macronutrients, micronutrient requirements, and fluid needs. All right, so we're going to talk first about compositional changes in the elderly. So as we age, there is decrease in bone mass, lean mass, and water content. And in the other side, we have increase in the total body fat, commonly with increased intra-abdominal fat stores. And we know the amplification of increased body fat, especially at around the intra-abdominal fat and the diseases related to that. And also the volume of distribution of many medications changes as a result of these shifts. And creatinine-based determination, we know that we have a concept that in the elderly population, creatinine-based determinations can overestimate renal clearance. And the reason behind this is because in the elderly patient, there is decrease in the muscle mass and muscle tissue. And that could be due to even malnutrition or malnutrition and the increase in the GFR, basically. So we cannot rely on creatinine in these people because, as we said, is overestimate the kidney function. And we cannot generalize well-standardized nutrient requirements of young or middle-aged adults to older adults. There is some challenges and difficulties in this population. Okay, so we'll talk about the metabolic needs, and that as we age, there is reduced basal metabolic rate. This reflects loss of a lean body mass, including muscle mass, as we said. And the basal metabolic rate is the principal determinant of total energy expenditure. So we have the estimation of energy needs based on body weight, 25 to 30 kilocalorie per kilogram per day. So we have to like make a balance between overfeeding and meeting the basal requirements. So we like taken only the calories that meet the basal requirements for the body, and avoid, of course, avoid the overfeeding. So we have like a food and nutrition board of the Institute of Medicine of the National Academics recommends prudent diet consistent daily of. So we have protein, fat, carbohydrate, and fiber, and obviously the vast majority of the calories that the population, elderly population should get is from carbohydrates, which has the between 45 to 65%. So we start with protein. So the requirement is 0.8 gram per kilogram per day, which equals to 1.5 gram per kilogram per day under stress. And the fat, it's in the middle, like 20 to 35% of total energy intake per day, with reduced cholesterol, saturated fat, and trans fatty acids. And as we said, carbohydrate has the vast majority of a total energy requirement, and especially complex carbohydrate as the preferred fiber source. Yeah, it will be like as even like intervention for avoiding constipation and so on in elderly. And the fiber, 30 grams per day in men and 21 grams per day in women. So let's talk about the normal aging and the challenges that these people face. So normal aging is associated with decreased perception of thirst, impaired response to serum osmolarity, and reduced ability to concentrate urine following fluid deprivation due to like decline in kidney function. So fluid needs of older adults can be met with 30 ml per kg per day, or equals to 1 ml per kilocalorie ingested. A decline in fluid intake can also result from disease states that reduce mental or physical ability to recognize or express thirst, like dementia and all the other mental neurodegenerative diseases, or that result from decreased access to water, like decreased functionality or disability. So even if they recognize thirst, some people, especially those that they live by themselves, they cannot access to water. So we have to assess all this. Dehydration is the most common fluid or electrolyte disturbance in older adults. So we have here the common signs of dehydration, although none of these are sensitive or specific. First one is decreased urine output, which it could be signs of dehydration, but as I said, is not sensitive or specific. It could be due to like renal failure or any other disease, and constipation as well, mucosal dryness and confusion. So these are like, we cannot rely on them, but they give us a good hint of the dehydration, like as a basic hint. Okay, so we have our tools, assessment tools. We have 5 tools: anthropometrics, nutritional intake, laboratory tests, drug nutrient interactions, and multi-item tools for nutrition screening. So we're going to start talking about anthropometrics. So anthropometric measurements, as anthro means like dealing with numbers and calculations. It's a tool often used for assessing nutritional status of older adults. These tools includes measures for weight and height. As we know, body mass index is the most important one. And the formula for it, as we know all, is weight in kilogram divided by height in meter square. Risk threshold for low BMI basically is 18.5 for the elderly. It should be interpreted in the context of the individual's lifelong weight history. So we have to look in the patient history, his weight, like over the years, and compare it like every visit. The nutritional problems or syndromes, we'll start talking about undernutrition. So we have unintended weight loss of 10 pounds in the preceding 6 months, which equal to 4.5 kilograms. It's a useful indicator of morbidity. It's predictive of functional limitations, healthcare charges, and need for hospitalization. And the minimum standard consider weight loss of 5% in 1 month or 10% in 6 months as significant, which is equal to 10 pounds in the preceding 6 months. So we have to see that the patient basic weight and see if there is decrease by 5% in 1 month or 10% in 6 months, like roughly. Undernutrition. Inadequate nutritional intake has been defined as average intake of food groups, nutrients, or energy, 25% to 50% below a threshold level of the RDI. So poor intake is often an indication of illness, as we know. 5% to 18% of nursing home residents do not meet standards for adequate nutritional intake. Most of the problems coming from like obtaining food commonly contribute to inadequate nutritional intake among older adults. And there will be too many causes. So it's very important to ascertain whether limitations is in resources or transportation or functionality, which may limit access to food or sometimes the ability to prepare and or to consume food, especially people who live by themselves. So we have to ascertain and know the principal cause of inadequate nutritional intake. Okay, so undernutrition is a risk indicator for morbidity and mortality. If someone can tell me how to take this label from here. Do you see it? The black label here.
No, we don't.
We didn't see it.
Yeah,
I can't see it.
there is like a box here and it's obscuring the top portion of the slide. So just let me
This
try.
one?
So
yeah,
the-
it's on the top of the screen. I don't know if you see it, guys, or not.
Oh, no, I didn't see it.
We don't see it.
Yeah, because, okay, give me a second just to try to.
You can click on it and move it to the right or the left.
Yes, yeah, thank you. Just let me pull it down. Okay. Yeah, it's better. Okay, so so we're gonna talk about drug nutrient interactions. So we have some medications can modify the nutrient needs and metabolism of older adults. Certain medications such as digoxin and phenytoin, even at therapeutic levels, can cause anorexia in older adults. Other medications are known to interfere with taste and the smell, and others can reduce the availability of specific nutrients. Yeah, we'll have a table after in the next slide talking about these medications. So, and also other medication can reduce intake by causing inattention, dysphagia, dysgeusia, and xerostomia. And all these factors are important to acknowledge. So medications that precipitate constipation can also reduce appetite. Yes, here's the table. So we'll go through the most important ones. And the first one is alcohol. Alcohol reduces zinc, vitamins A, B, and B1, B2, B6, and folate. And the most important one is folate and vitamin B12. And antacids interfere with vitamin B12, folate, iron, and total kilocalories. And antibiotics, and especially broad spectrum antibiotics, interfere with the availability of vitamin K. And colchicine with vitamin B12, digoxin with zinc, and total kilocalorie, diuretics with most of the electrolytes like magnesium, potassium, and copper, and also vitamin B6. And isoniazide, as we know, vitamin B6 and niacin. Laxatives will interfere with calcium, vitamins A, B2, B12, D, E, and K, and levodopa with vitamin B6. Okay. And we have the lipid binding resins, obviously with the lipid soluble vitamins, which is the A, D, E, and K, and metformin with vitamin B12, and mineral oil with vitamin, also the lipid soluble vitamins A, D, E, K, and the phenytoin with vitamin D and folate, salicylates with vitamin C and folate. And SSRI is it causes anorexia, so it interferes with the total kilocalories. The same thing with the theophylline, and trimethoprim with folate. So these are like examples. That's why it's very important to go through the medication history for the patient. So, and the next tool is the multi-item with nutritional screening. So we have like 3 or 2. The first one is mini nutritional assessment. It has 18 items, requires administration by a trained professional, and this is one of its limitation. It has a short form which consists of 6 items. Evaluates the risk of malnutrition among frail older adults and to identify those who may benefit from early intervention. It's available as an app for like phones and tablets. And the second one is simplified nutrition assessment questionnaire, and as the name applied, simplified, as it can be answered by patients through the mail or while sitting in the waiting room. The sensitivity and specificity of this questionnaire is 88.2 and 83.5%, respectively, for identifying those at risk for weight loss, which is really good. So we'll talk about something very important to identify, which is the risk factors for poor nutritional status. So we have alcohol or substance abuse, cognitive dysfunction, decreased exercise, depression, poor mental health, functional limitations, limited mobility and transportation, inadequate funds, that's a big problem, limited education, medical problems and chronic diseases, medications, as we mentioned before, poor dentition, which is very important in this population, restricted diet and poor eating habits, and social isolation, which is for me, it could be the most important one of these. Nutrition syndromes. We'll start talking about involuntary weight loss. So involuntary weight loss, it's the unintended weight loss. It's clinically important weight loss is, as I mentioned before, the loss of 10 pounds, which equals to 4.5 kilogram, or more than 5% of the usual body weight over a period of 6 to 12 months. A BMI less than 18.5 is an indicator of poor nutrition. But if it's below 17, it's more serious. It's associated with undernutrition. Excess loss of lean body mass is associated with poor wound healing, infections, pressure sores, decreased functional ability, and mortality. So involuntary weight loss is present in approximately 13% of older outpatients. 25 to 50% of hospitalized older adults, and more than 50% of nursing home residents. Okay, so we'll talk about the etiologies of involuntary weight loss. The vast majority, which is 50%, it's organ-related, like chronic diseases, say like congestive heart failure, COPD, renal failure, chronic infection and inflammatory states, and also GI conditions, and adverse medication effects and neurodegenerative conditions like dementia and delirium and other stuff. And 20% related to neoplastics, and other 20% is idiopathic, including sarcopenia associated with aging. Okay, and sarcopenia is the decrease the mass index and the muscle mass of the body. And 10% could be due to psychosocial conditions. So I bought this picture from the web. It's talking about sarcopenia. So aged muscles, the two contributors to sarcopenia is mitochondrial dysfunction and cellular senescence. So the mitochondrial dysfunction, like increase oxidative stress, increase ROS production, alter dynamics, and all the stuff inside the cell, alter mitophage or morphology, and it decrease ATP production, and decrease energetic and decrease biogenesis. And in the other side, the cellular synthesis associated with increased telomere erosion and DNA damage, and the another elements like the other cell elements. Like the interleukins and chemokines and growth factors. So all these contributes to sarcopenia. Yeah, here's an imaging for young, healthy thigh muscle. We see how bulky it is. And sarcopenic thigh muscle is like shrink and yeah, decrease in the diameters of the thigh muscle. And evaluation should include careful documentation of weight over time and detailed history, including medical, as I mentioned, to know the patient medical history very carefully, dietary and psychosocial elements, and also physical examination, focused additional testing based on the history and physical and limited standard laboratory profile. In a situation of treatment of underlying cause, and appropriate follow-up to assess response to management. Nutritional therapy should include dietary education, removing dietary restrictions for chronic conditions, unless it's shown to be effective, because most of the dietary restrictions showed no effective in decreasing mortality or morbidity. And nutritional supplements given between meals, and multivitamin and multi-mineral supplements. Okay, now we're going to talk about the extreme, the extreme opposite of undernutrition, which is obesity. So our goal is to achieve a more healthful way to promote improved health, function, and quality of life. Use a combination of prudent diet, behavior modification, and physical activity. For frail, obese, older adults, emphasizing preservation of strength and flexibility rather than weight reduction in this population. So from the National Institute of Health, age alone should not preclude weight loss treatment for older adults. A careful evaluation of potential risks and benefits in individual basis should guide the management. As we know, always prevention is better than treatment, especially here. So preventing undernutrition is much easier than treating it. Enhance the food intake by catering to food preference as much as possible. avoiding therapeutic diets unless there is clinical value, it's certain. Placing this about like in the nursing home or hospitals, like placing 2 or more patients together for meals can increase sociability and food intake. And also we should pay great attention to in preparing foods, like appropriate consistency, attention to colors, arrangement, and temperature and texture for these people, and using some herbs, spices, and hot foods help to compensate for loss of the sense of taste as we age and smell. And also it's very important to avoid excessive use of salt and sugar and other preservatives. And avoiding hard to open individual packages. So like try as much as we can to make it simple, simpler for them, and given adequate time for chewing and as we said, for sociability during the mealtime. Okay, now we're talking about the nutritional supplements. So nutritional supplements come in the form of bars or some liquids that they have them over the counter in stores or in the supermarkets. So the use of micronutrient supplements is growing. Approximately 60% of older adults take self-prescribed dietary supplements. Many vitamin and mineral supplements are commonly available, as we said, in supermarkets and stores. They're generally safe, except for excessive intake of some like vitamins A, D, and iron. So we have to pay attention for that. It's the job of the the physician to check the appropriateness and the safety of each supplement. Yeah, because like many individuals, they may be unaware of the adverse effect of many over-the-counter supplements, and also there is no solid evidence in the favor of these supplements. So yeah, we have to take a good history and educate the patient as much as we can. And imperative that the clinician obtain information about the patient's use of all supplements, like prescribed or the over-the-counter ones. Okay, so talking about vitamin D deficiency, it occurs in 30% of individuals more than 70 years old. It's associated with impaired calcium absorption and reduced physical activity level. Insufficient evidence to screen for vitamin D deficiency in asymptomatic adults. So it may be appropriate for older patients at risk for deficiency, like people with weight loss and malnutrition. There is current recommendations for all older adults include daily intake of calcium in the dose of 1,000 milligram and vitamin D 10 microgram to prevent osteoporosis. Okay, and we talk about drug treatment for undernutrition syndromes. There is no reports demonstrating improvement in long-term survival, and on the other hand, it may cause serious adverse effects. So the adverse effects associated with medication, most used off-label, used for treatment. So, for example, we have mirtazapine. And when prescribing mirtazapine, caution with doses more than 15 milligram per day due to hepatic and renal insufficiency, which already impaired in the elderly population. And we have the cyproheptadine. It can cause confusion. Migestrol, it's on Beer's list, so it increased the risk. Also, it increased the risk of DVT and fluid retention, edema, and congestive heart failure exacerbation. It may negate effects of exercise on strength and function. And we have the dronabinol, it causes somnolence and dysphoria, so we should be aware of all these adverse effects. And human growth hormones, of course, they are contraindicated in cancer states, and hyperglycemia with the fluid retention. And anabolic steroids, there is no significant improvement in strength or function or reduction in fractures. So it's better to avoid them. Okay, now I'm going to talk about legal and ethical issues. So basically, food and fluids should always be offered to all patients. The decision to start or to discontinue artificial nutrition or hydration must be considered very carefully. Competent adults may choose to forego artificial feeding as any other procedure or decline it. Advance directives should be honored unless there is compelling evidence that the individual would have changed his or her mind in the current. Okay, so in incompetent adults without advance directives, the decision to start or continue to discontinue, artificial feeding should be considered carefully with the surrogate. So we should take into account the risks and burden of such an action, the risks and burdens of alternative actions, and the evidence to support likely benefits of the various actions. Current evidence does not support the use of feeding tubes in patients with end-stage cancer, dementia, or COPD, as the risks are outweigh the benefit. So palliative care, including emotional support, is extremely important at the end of life. So here we come to the summary. So nutritional concerns affect many aspects of health and disease in older adults. Acceptable parameters of nutritional status, such as body weight and protein levels, should be maintained unless the patient's clinical condition demonstrates that this is not possible. There are many tools to help screen and assess for nutritional deficiencies, as I mentioned them before, and the cultural factors play a role in nutrition intake. Here we come to the cases. We have 3 cases today, so I'm going to start with the first one. An 88-year-old man comes to the clinic because of an intentional weight loss over the last year. He has lived alone since his wife's death 12 years ago. He's accompanied by his son. His son has managed his finances for the past 12 years. The patient is otherwise independent and continues to drive himself to local stores. The son says that his father is less active socially than in the past and spends most of his time watching television. The patient says that he eats and sleeps well, has no depressive symptoms, weakness, or dizziness, and has had no change in bowel habits. He has had no surgery or serious illness in the past 10 years, and he takes no medications regularly. Colonoscopy done 2 years ago to evaluate minor hematochezia was normal. So on examination, his weight is 37 kilograms. It's 14% lower than 1 year ago. His body mass index is 23 kilograms per meter square. The remainder of examination findings are normal. Focal GUIC is negative. His score in MSC was 28/30, and in the patient health questionnaire, it was 0. The score was 0. Lab findings was a normal urinalysis, CBC, electrolyte, normal liver, kidney, and thyroid function, and also normal chest radiography and EKG. The question is, which of the following diagnostic evaluation is now indicated? Choice A, no further diagnostic testing. B, CT scan of the chest, abdomen, and pelvis. C, upper and lower endoscopy. And D, low-dose dexamethasone suppression test. So we're going to stop for a minute or so. See the answers. Yeah, some people are saying A. Yes. Yes. Yeah, so the answer is A. So the basic laboratory testing for this patient was were normal. and there is no history of like blood loss, or the patient has no depressive symptoms, so we don't need to do any. And his colonoscopy was normal, as we said 2 years ago, so he's good to go. So no further diagnostic testing is required. All right, so we go to the second case. So it's an 81-year-old woman was admitted to the hospital 3 days ago because of hypotension, depressed sensorium, and urosepsis. 5 weeks earlier, she had perforated gastric ulcer and sepsis. Her post-operative course necessitated prolonged stays in the hospital and nursing facility. And in the current hospital stay, she responded to IV fluids and antibiotics and is now alert and cooperative. For the last 2 days, she has been on a regular diet with polymeric oral nutritional supplements between meals. Nurses' notes indicate that her nutrient consumption ranges from 25% to 75% of meals. On examination, her weight is 64.4, down from 69 kilogram 3 months ago, and her body mass index is 21.6. There is an uninflamed surgical wound, which is being allowed to heal by secondary intent, and there is +4 peritibial and thigh and presacral edema. Serum albumin is 2.7. So the question is, which of the following is the best option at this point to determine the patient's need for additional nutritional support? A, screen for nutritional risk using the mini nutritional assessment. B, obtain serum pre-albumin level. C, order calorie counts for 3 days. D, measure biceps and triceps skin fold thickness and arm muscle circumference. Okay, some people are saying A, which is a reasonable choice. Okay. A, I see some C. Yes. All right. So this patient basically has lost like 8 kilograms from her previous 6 months ago. So we should be evaluating her, and the answer is C. So we start with the simple intervention, which is order calorie counts for 3 days to make sure this patient is taking the enough amount of calories before going any further. Okay. All right, thank you, everyone. The last case is we have a 69-year-old man is transferred to the medical unit after spending 6 weeks in the ICU for ventilator support related to post-influenza pneumonia and acute respiratory failure. A percutaneous esophageal gastrostomy tube was placed 4 days ago before transfer to the medical unit. The patient was started on a polymeric feeding solution, 1.2 kilocalorie ml at full strength. Okay. The target that was set is, okay. Excuse me, just give me a second. All right, so I'm back. A quick recap of the case is 69-year-old man. He was transferred to the medical unit after spending 6 weeks in the ICU for ventilation and post-influenza pneumonia. There is a tube was placed 4 days ago before he was transferred to the medical unit. He was started on a polymeric feeding solution, And the target rate was 70 ml per hour, but the feeding rate has not been increased beyond 25 because of the development of multiple liquid stools daily. Despite efforts to identify the causes of the patient's anorexia, his volitional nutrient intake remains near zero. The patient has no history of CDEF, and there were no cases of CDI in the ICU or his hospital ward for the last 2 weeks. He has had no nausea or vomiting, abdominal pain or cramping or tenesmus. He has not taken medications that contribute to diarrhea, and contaminated formula has been excluded. Before hospitalization, his weight was 72 kilograms and body mass index was 23 kilograms. Okay. On examination, the patient is alert and oriented, and temperature is normal, and weight is 64. So it's there is scatter bronchi and disease in both lungs due to his pneumonia, but there is no crackles. JPB is normal. Everything else is normal. The tube is in place. In the lab, everything is normal except a mild decrease in the abdomen. And hemoglobin is 10.4. So findings from a liquid stool sample are negative for CDEF, and the other lab test for CDEF, which is the glutamate dehydrogenase A and B, swallowing evaluation is ordered. So the question is, which of the following should be done next to improve the patient's nutritional status? A, prescribe lubrimide, start total. B, start total parenteral nutrition. C, start dysphagia diet, hand feeding, or D, refer for jejunostomy tube. All right, so I see people are answering it. D. Okay. A. Okay, so the answer is A. The answer is A, which is prescribed lubrimide. So this patient has functional diarrhea, as we excluded all the. We could exclude all the infectious causes of the area, so we just go with the anti-diarrhea agent, which is the lubrimide. So everyone, this was the last case here in my presentation today, and thank you for listening. If anyone has any question, please go ahead.
Thank you, Dr. Monia, for this great presentation. And now, anyone, if you have any question or any suggestion, go ahead and ask.
Thank you so much, Dr. Monia. This is great presentation. Excellent. Thanks for
listening.
Thanks.
I have a question regarding supplement vitamins. So is there like any evidence-based medicine regarding supplementary vitamins for any elder patient?
So from my researches, it says that there is no benefit, no risks. So it's it's about the patient if he prefers to take, apart from like vitamin D and calcium, and after lab examination, if you, or like we can give them as prevention for osteoporosis. But I didn't see like a solid evidence supporting these supplements. So if Dr. Nader has and
No,
we
I
can
do agree. So it's just supportive things that we can offer the patients if they are able to take them. And usually I prefer the resource like the natural resources. So if they can eat salads, eat fruits, vegetables, then these might have plenty of vitamins. Sometimes you may add some tablets. So in nursing home settings, sometimes we offer the multivitamins because they are frail patients. But that also we assess, and if they are on multiple medications and now they are not swallowing or they are not doing well. So this is just, it's gonna go away, the multivitamins and other supplements.
Is there like any result from studies regarding this issue?
Monia, have you seen any?
no. Yes.
No, I haven't. Maybe we can look that up, and next time we can
Yeah,
discuss.
because it seemed like routine for any elderly, so he get like multivitamins as routine every morning. So that I don't know why. Okay.
Yeah, some comes from the hospital with this or from primary care. So we need to assess and always see what the benefit versus the risk. If there is no risk and some benefit, yes, we can recommend that or continue that. If there are some risk with it, then we can just.
And what about the vitamin D and what calcium?
Anything to add, Monia?
Yeah, as I mentioned in one of the slides, the recommendation for vitamin D was like 1,000 milligram per day, and for the calcium, 100 microgram. Yeah, and it's
It's
basically
like
like for,
prophylaxis, you mean?
yeah,
Prophylaxis?
as prophylaxis, especially for postmenopausal women or for elderly men, as prevention. But I don't think it's important as treatment for. I'm not sure though. But these are the most famous or important vitamins or minerals to supplement.
And regarding herbal, any studies, anything about it?
You know, some herbs may be like inducer or inhibitor for the cytochrome B450, as we know. And there is a lot over the counter, but I think for herbs, they are more risky than being beneficial, especially the interaction with other enzymes and and of course other drugs. So it's better to avoid them, as I read in one of the articles.
Okay, thank you again, Dr. Monia, for this great presentation on this informative topic.
Thank you so
much. Next, we have like two topics, but I don't think there is anyone show up to present these two topics, and I don't have like any update till now regarding them. But we can continue our presentation. We have like two topics. One of them regarding research, how to write manuscript, and the other topic is the reason for rejection of research when you submit it to any journal. So I'm going to give you like a quick idea about these two topics. If that's fine with you, Dr. Nadir.
Oh, sure, yeah. Thank you.
Good. Did you see my screen?
Yes, yes.
Okay, how to write a manuscript? So first of all, the first page, this is like a skeleton for how to write manuscript. So the first page of manuscript should be arranged as follows. The title on the first page, abstract, text begin on page 3, introduction, method, then participant, apparatus for materials and procedures. Then the result, discussion, references, evidences, author note, footnote, tables, and figures. The title page, page header, page number, running head, title, author name, and author affiliation. Then the abstract. The abstract would be like a small picture for the whole manuscript. So the abstract is always the second page. Center the word abstract should be in the center of the page. Only the first letter is capitalized. Do not italize or underlines anywhere. Do not indent first word of the abstract. Use one paragraph only. No more than 120 words on the abstract. The purpose of the abstract, review problems under investigation with a single sentence. Then review methodology, participant, apparatus, material, procedures, review result, conclusion, and implications. And you have to write concisely. Method. The word method is centered and is not underlined or italicized. The participant, material, and procedure heading are not centered or indented, but are italicized. And the text begins on the next line and is indented. So for the participant, you have to write who is participated, how many participated, how they were selected, and then identify participant characteristic like gender, age, and ethnicity. Materials and procedures. Use the metric system. So do not use any other system. So you have to use the metric system, not in inches or feet. So you have to use it in centimeters. Review what was done to the participant from the beginning to the end of the study. Then the design of the experiment and how participants were assigned to each group are mentioned in this section. Group abbreviations. It is easier for the reader if meaningful initial or numeral are used for the group name rather than meaningless letter or numbers. And avoid sexist language such as he or she. So instead of that, you can use they, except when a male or female is explicitly referred to, unless it's specified for the person. So you have to use they instead of he or she. Rule for using numbers. General rules. Numbers 10 or above are expressed as numeral. 9 or below are written as words. So you can say 1, 2, 3, 4, and so forth. but above 10, you have to write it as number. Some exception to the general rules are measurements are always numeral. Statistical functions are always numerals. Group of numbers with one value above 10 are always numeral. Numbers that indicate a specific place in a series, like figure 1, group 4, trial 6, are numerals. If a sentence begins with a number, it is always a word. So you don't have to make it like numbers. So you have to make it like words. For the result, the heading should be centered. Purpose, to summarize the result and statistical analysis. So it should be summarize the result and statistics. Result can be summarized through figures, tables, or in the text, but can only be presented once. Statistical result. When reporting means always include associated measures of variability. Examples, standard deviation and variant. The letters that represent the type of test used in italicized only if it is not a Greek letters. Note that the symbol for chi-square is not italicized. The number in parentheses represent the degree of freedom, df value. So do not type the letters df, just you put the value. The p is always italicized, b for statistical significance. Do not confuse the smaller or less than sign with bigger signs. Give a verbal description of the result, end the statement with comma, and follow the statement with statistical evidence. Do not interpret the result in result section. So refer to a specific table or figures in the text. Figure 1 indicates so-and-so, so the reader will know when to refer to these tables. The figures are placed at the end of the manuscript, but will be inserted in the text when printed. When a specific figure and its number are referred to, figure is capitalized and numeral is used. If the results are summarized in a table, the word table 1 must be mentioned in the text, so the reader will know to look for the table and then provide brief description of the result seen on the figure or on the table. Tables. Each table is placed on a separate page. Place the page header and page number on the top of each table. Table number and title are placed on the top of the table. Table 1 is not italicized. Table 1 is not indented or centers. The first letter of each main word in the table title is capitalized, and then the table title is italicized. Figure and captions. The page is title, figure, and caption, and the title is centered. Figure 1 is italicized. Nothing intended on the figure caption page. All figures captions are placed on the same page with figure clearly numbered. Figures. Each figure is drawn on a separate page and is placed after the figure caption page. Page is not title or numbered. The vertical axis should be about 2/3 the length of the horizontal axis. If either axis does not begin at 0, double slash mark must be made to indicate discontinuity. All axes must be labeled. The legend that identifies the group name appear within the axis on the figure. Do not put the figure caption the same as figure title on the figure. It is placed on a separate page at the end of the report. Figures are drawn in black, so do not use any color. Regarding references, so there is some tools for references, but here is the rule how to write the references. But many tools have built-in built-in reference criteria, so they can make it ready for anyone. Just you have to get them. Center the heading. References are not numbered. All references are in alphabetical orders. Rule for journals articles. So the last name appear first, followed by the initials. The first line of each reference is flush left, and subsequent line are intended like 1 inch. The ampersand sign is used if there is more than one author, and there is a comma before the ambassador sign. The year appears in parentheses and is followed by a period. The first letter of the first word is only one that capitalized in the title, and the title is followed by a period. The name of journal articles is not abbreviated. The journal title is italicized, and the first letter of each main word is capitalized. The volume number and the pages follow the journal title. All numbers are separated by comma. Do not use the word volume or pages. Only the volume number is italicized and end with a period. Reminders, write clearly and concisely. All pages of manuscript are double spaced, never single space. Plan on writing a mini draft before the final one. Proofread your final version and correct spelling, typing, and grammatical errors. Make sure that you have not missed a section. Be sure that the sections are in the correct order. The end. So this confirms that editors that no pages are missing. So the end should be on the last page. That means there is no any missing pages after this point. Thank you. Anyone have any questions? So go ahead and ask your question. Is there any question regarding manuscript?
Thank you so much, Dr. Osama. This excellent review for how we can write a script step by step. Thank you so much. Any questions for Dr. Osama, or we can move to the next topic?
So the next topic will be quality of research, how to develop a quality research article and avoid a journal desk rejection. So it will be like the cause and how to resolve the problem to your submission to be accepted. So reason and sources, first, lack of adherence to journal or author guidelines. So you have to follow the guidelines of any journals, and you have to check for the guideline first. Journal differs on their requirement at the desk review stage. However, lack of adherence to author guidelines. Submission length. So also you have to know how much they need. There are specific word count limit by various journals. Some variations are tolerated, but submission with much higher word counts are unlikely to pass desk screening. So many journals allow manuscript length up to 10,000 words, but check the guideline for each journal. Grammar and poor writing and formatting related issue. So you have to check your grammar issue, declarative versus exploratory. So you can use any tool like Grammarly, for example, just to make sure that your writing is neat and no any grammar errors. Lack of fit, lack of relevant to journals readership, aim and scope. Many submissions have no direct relevance to journal subject domain, although such submission can be interesting and well written. Editors are forced to reject such submission. So due to lack of fit with the journal and lack of relevance to the journal readership. Resubmission a rejected paper to a new journal without any improvement will be rejected again. So if you need to resubmit any manuscript, so you have to make some work and you have to revise it and then you can resubmit it to the same journal or to other journal, and always prefer to another journals. Under developed papers, premature submission, poorly organized and developed, poor preparation, not coherent. So all of these are causes of rejection of your research. So underdeveloped submission will not be sent to reviewer and rejected at the first stage. So even it will not go forward for the reviewer. Some of the symptoms of this submission include submission that is too short, poorly structured, or not coherent, and suffer from grammatical and spelling mistakes. Suggest to improve submission through feedback or by inviting comment from experienced author published in target journals and or editorial review board member from the target journals. So you have to make sure that your submission will be accepted without any underdeveloped paper or premature submission or any mistakes. Lack of familiarity with existing work published in the target journals, not connected with existing research conversation in the journals. So any lack of familiarity may mean that the submission may not have a good fit for the journals, and it may be outside the expertise of AE and editor reviewer board. So mode of presentation may not be aligned with one followed by the target journals, and it may not be relevant to the journal readership. Lack of robust theorization does not build or test theory, just testing a well-established theory. So a list of hypotheses without suitable justification and a collection of construct without coherent and logic do not constitute theory, and this is easy to spot. So you have to make sure that you have a solid theory and you have a solid questions that need to be answered. Similarly, just describe result in qualitative submission and presenting descriptive account of existing study in a review article does not constitute theory development or building that is prerequisite for publication in any high quality journal. So make sure that you test your theory and you test your question, and that will benefit international. Lack of methodological underpinning and writers. Single administration self-report survey instrument. Inadequate description of various aspect and or not meeting the standards suggested by literature from the subject area. For example, multi-source, multi-administration data collection method is prerequisite to publish in many high-quality journals. So you have to make sure that first you have to check your data and you have to check from where you get the data. Submissions that have utilized data from a single cross-sectional survey get this rejection from the first time from such journal. So survey measures are poorly validated and or survey measures are not included in the manuscript. So data might be too old or sample size are too small. So these are some of the causes of rejection too. Insufficient research contribution or lack of novelty. It is important for manuscript to show that the researcher presented is new, innovative, relevant, and significant. So you have to represent a valuable topics or valuable theory and questions. A topic may be saturated as several articles are already published on that theme. Plagiarism, extent of similarity with other sources, or self-plagiarism. So several submissions include a large portion of their content either from other sources or from their own previously published articles. So journals are now screening and desk rejection most of submission due to inadequate originality. And there is some tool like Turnitin. So just they put the article on that tool, and it will give the similarity and percentage and where it came from. So there is no any way for cheating or for get any large proportion of any content from other sources. Duplicate submission or previously rejected submission. As I told you that it is wise not to resubmit for the same journal. Author resubmission their previously rejected submission. Many journals and editors have that policy not to consider previously rejected submission. Even some journals rejected any rejected submission, unless a rejection notification clearly stated further opportunity for resubmission. And it is not appropriate to submit in the same journal again. Advices and guidance for researcher for this type of rejection. So this like some of the idea or like solution for this type of rejection reason and how to overcome these rejection reasons. Insufficient research contribution or lack of novelty. So communicate the novelty and significance of the study in the cover letters. Include literature review table to demonstrate contribution against other relevant articles. So you have to include everything you did, like tables, figures, anything you have to have like some sort of contribution that can check it at any time. Look through editor lens, and the 15-minute test where the abstract, introduction, methodology, and conclusion are read in 15 minutes to judge whether novel insight exists into a research phenomenon that the editor was not aware of. So the abstract will be like reflection for the whole result or for the whole research. So if it is accepted, most probably the research will be accepted because it gives you the whole idea about or the picture of the research. Tell a single story from start to finish. So you have to be focused. Author must convince that the editor and their work offer a suitable contribution that is of international significance. So you have to represent significant topic or significant innovation. Researchers tend to either over or undersell the contribution of their work, ensure the novelty claimed in the abstract align with that in the finding, and demonstrate how the research align with that of the journal and explain why and how it will enhance the value, contribution, diversity of the journal. So you have to show them something that to accept your work. Clearly identify the research gap addressed and clearly substantiated the claim of new contributions. And always ensure that the paper make a clear and well-articulated contribution. Do not leave this to the last section to make this known. So you have to tell them from the first that what you are going to represent. Lack of robust authorization does not build or test theory, just testing a well-established theory. Review relevant theories and apply them to support your argument and proposition, explaining how you have contributed to theoretical development by extending current theory or developing new theoretical understanding, concept, or models. Be pragmatic in assessing if the paper provide a significant new theoretical and practical contribution. So try to represent something that new ideas. Manuscript should be demonstrate adequate consideration of relevant theories in the field and the contribution development. Single study with cross-sectional data unlikely to make the level of contribution expected by high-quality journals. As I told you, that you have to get like multiple studies, not depend on one single cross-sectional study for your work to be accepted. Submissions should demonstrate advancement of theoretical boundaries and advance existing debate. So you have to answer existing debate by your research. Lack of methodological underpinning and rigor or single administration self-reported survey instruction. Methodology must clearly explain the research process undertaken to investigate the phenomenon and draw upon appropriate method, literature, and academic precedent. Researchers should ensure rigor and robustness of research methodology to negate editors' viewing submission as fault by design and desk rejection from the first time. Thank you. This is my presentation regarding research quality. If anyone have any questions, so go ahead and ask.
Thank you so much again, Dr. Osama, for this great presentation as well. Any questions? If none, we can move to the next. I will be talking about the artificial intelligence. I know we talked about it last week and previously, but I want to share with you some of the things that I think might be of help to you guys. Let me just share the screen here. So there is a website where you can go to the Open Artificial Intelligence, openai.com, and this is a platform. It has some examples. If you go to the first page, it will list some of the applications, how you can use the artificial intelligence, but they have some examples here. If you are new to the concept, there are some questions and answers, and there are plenty of how or can you use the artificial intelligence. If you are a programmer, you can use different programming languages. But for physicians or for you as a researcher, if you go down, you can use, for example, here, artificial intelligence can be used to identify what color respond to what mood the person is having, for example. If you go here, an essay online. If you want to write some concepts, it can help you. If you write an abstract, for instance, there is a way, there are different tools, but there is a way to check the English language, for example, somewhere here. And the funny thing is the chat one. The chat, if you want to use it, you can use it as a way of helping you write some, let's say I'm interested in writing an abstract about a topic. So I will just tell the AI in a sentence, like, help me write, for example, the dementia and telemedicine use in preventing falls. So it will start writing the background and the importance of patients with dementia and the risk of falling and the impact of falls with injuries and the cost of that as a background. And then it will identify certain area for you to write as an aim of your study. And then it will suggest some way of methods. Let's say you want to identify patients in nursing homes. So it will modify your idea or suggest that we identify certain patients in nursing home setting with use of whatever tool that can be used to assess risk of falls, and we use whatever, let's say, telemedicine assessment, and then it will put some numbers that we can modify, and then the results section will be, we found this, and at the end it will write a brief conclusion or the summary of what you have done and the future direction for you. So it's nice. And if you repeat the same question, it will rewrite, but with a different way of, like the background will be differently, the setting and the participant and the method might be different, and the conclusion definitely will be different than the first one. And you can repeat this until you find something that you might match what you're thinking about. So you will have a backbone or skeleton where you can build your own abstract, and then you can carry on the methods the way you want to do it. It's easier, it's faster, it's very useful. I attempted to use it and I found it very helpful in certain section. Next time I will show you what I did with it, but it can be very, very helpful tool for you guys. So if you want to look at that website, play with it, see if you can find anything that's useful in this kind of tools, and let me know. The other thing is they tested it in medical schools, or and it passed USMLE, I think step 1 or something. So it's very up to date as far as information, current information that is used. So it's helpful. I'm not sure if we can use it also for writing papers, for example, manuscript, but definitely it will help make the skeleton for you if you want to write something. So as a team, we can identify a research question, and we can tell the chat OpenAI how to carry on a manuscript, and then it will at least lay down the foundation, and then we can build on that. So it's a very useful tool. Try to use it, see what ideas you can make out of this. This is part 1. And the other part I want to share with you is how you come up with some questions, like let's say you don't have an idea about writing an abstract or a manuscript. How can you get new ideas, new questions, and then follow on that? So what I do usually, I go to PubMed, and then I will look at what is in the literature. For example, this mobile apps for caregivers for older adults. This was done in 2018, and it's quantitative content analysis. So I'm gonna read what they did, the methods section here, and see if I can repeat that. So it's been like 4 years, 5 years. So if I repeat the same topic with the same method, maybe I will find different results, or I can confirm the same result, or I can come up with new information, because in the last 5 years, most likely the apps are different than in 2018, 2017, especially with COVID, with the pandemic, with patient and people staying at home remotely doing things. Then things are changing fast. So in the past 2 or 3 years, definitely is different than 2018, what we call post-pandemic, before pandemic, so pre and post. So we can, for example, we can use the same concept. Instead of the mobile apps for caregiver of older adults, we can add it as pre and post COVID, or comparison before COVID and after COVID. So this is the idea of an abstract that you can do. The only thing is you focus on the method. You can repeat the same method, or you can modify it and use a different method. And more or less the background might be the same. Objective will be assessing what's new in this area. Hopefully the conclusion will be an outcome that's beneficial for anyone who reads the article or the abstract. So this is an easy way to write an abstract, and you can submit it to, let's say, AGS, American Geriatric Society, or Gerontology Society, or AMDA, or other specific, if you want to go for technology, for example, group, they have many conferences. So there are plenty of opportunities to present their work. If you want to specify, let's say, all the adults with dementia, so you specify a certain group, then if you write the abstract, then you will have Alzheimer's Association, for example, or caregiver of all the adults with multiple sclerosis, then you will have multiple sclerosis convention or some conferences. So you can find a way to present, or a conference or meeting to present your abstract. This is a faster way of doing work, like getting ideas and writing abstract. If you have more information, let's say you have time and you have the abstract done and you already submitted to one of the conference, you can also, out of this abstract, elaborate and write it as a full manuscript. So you will follow the same sections or points where Dr. Osama mentioned. You will start with your abstract about the topic, and then you go to the introduction. You will have plenty of information here as far as you want to document that there is an issue or there is impact. And then at the end of the introduction, we'll have the aim, what you want to do. So you explain that in this section, and then you start your methods, and whatever results you have, you can put it in tables, in graphs, analyze that, and at the end, you can use a discussion part where you will elaborate. You can say, we looked at the previous studies done in 2018, and during the pandemic, things changed, and we now looking at the same question, but in a different way post the pandemic. And this is our findings, and we think whatever ideas you can come out with, and this will be your future direction. Any recommendation for more research out of what you found. Sometimes at the end, you may put the conclusion. You can discuss what the weakness, what the, if you have acknowledgement, any grants or any support from any places. And then you can put your references. So this is how you come up with an idea. If you have short time, you can not duplicate the same abstract, for example, but you get the idea and then compare it in 5 years or in 10 years. If you go back to same concept, maybe you can find something in this. Let's say I read this abstract, I have interest in this, I read the whole paper. At the end, when you go to the references, from the references, you can go back to the background. Maybe in 2005 or 2013, they talked about something. So now we are talking about 2023, so 10 years gap. So maybe you can find some other topics that was started and written about in 2013. And now we can talk about the same topic in 10 years. What happened? What changed? What's new? And by the same token, you can talk before COVID and after COVID. And then as long as it's all the adults, you can target AMDA, for example, or Geriatric Society or whatever area. If you are in the psych and psychiatry area where you want to pursue that route, you can focus on all the adults with psychiatric symptoms or something like that. And whenever you can find some topic, you can come back and compare it as far as the 2 time period when they presented or published that topic, and now, if there is any changes or expected changes. So this one way of coming up with new ideas from looking at older publications or older abstracts. An easier way is to look at the previous conferences where they presented. ACP, for example, they have every year annual conference or meeting where they present some topics. So you can look at all these topics and see which one you might be interested in, and then you can compare the same topic before COVID and after COVID. Let's say in 2018, what people were talking about in their abstracts, or 2019. Look all the topics, all the abstracts presented there. Then you will find some interesting area or matching your interest. Then you want to focus on this, read about the topic, how they did it, the method, and then see if we can repeat the same method. And then the title will be comparison in 5 years or before or after COVID, something like that. So I just want to share with you, and hopefully this will help. Oh, I didn't share the screen. Any questions? So this is the app or the abstract, a mobile apps for caregiver of all others. So this is a good opportunity. If anyone interested, you can look at this and then maybe you can create a new idea from this topic, see what they did, if we can replicate the method, and then we'll see what the results. Any questions? If no questions, we can go to the last topic where we will discuss about the updates. Anyone with any updates as far as your projects going, or anything that you want to share?
Assalamu alaikum, Dr. Nader. How are you?
Alaikum assalam wa rahmatullahi. I'm very good. How are you?
Alhamdulillah. I just wanted to share that, alhamdulillah, our research got accepted by the American Academy of Neurology.
Excellent. Congratulations.
Thank you so much. I had an amazing team. So, inshallah, we're supposed to present in Boston in April, inshallah.
April. Oh, perfect. Excellent. That's good. It's a big conference, so congratulations. That's a great one. Anyone else? So you can start your team and work on the poster, and next step, who will present, how we can get there. Thank you.
Yeah, thank you.
Keep me posted if you have questions or any concern.
I really appreciate that. Inshallah, we're supposed to get an updated email sometime this week, but I will reach out to you for sure because it is a bit new for me regarding the poster submission. But thank you so much for your continuous help. We really appreciate it.
You're welcome. And if you have a minute, also CC or send me a copy of the email of acceptance and anything.
Okay, absolutely.
Yeah, thank you.
Okay, thank you so much.
Anybody else? I know also other people got accepted in AMDA, other posters. Any other questions or any updates? If no updates, I'd like to thank everyone and all the presenters, Dr. Osama, Dr. Monia, and we'll see you next week. Wishing you all the best. Thank you. Have a good day or good night. Assalamu alaikum.
Thank you, Dr. Nader.
Thank you, Dr. Nader.
Thank you so much, Dr. Nader.
Thank you very much, Dr. Nader.
Thank you so much, Dr. Nader.
Thank you, Dr. Nader. Assalamu alaikum.
Thank you, Dr. Nader.
Thank you, Dr. Nader. Thank you, Dr. Nader.
Okay, everybody.
Assalamu alaikum. Thank you so much, Dr. Nader, and everyone.
Assalamu alaikum. Thank you. Dr. Amal, if you're still there, any updates as for the app?
Hello, Dr. Nader. How are you?
Very good, alhamdulillah. How are you?
Alhamdulillah, khair. So regarding the app and the Google Play stores, I did not start the process yet, but I did a Google search about that. So I found that the best way to upload my application in app or Google Play stores is to recreate the application again using the coding language. This is the best way. So other alternatives
What language?
include a coding language, like recreating the application again using coding.
Coding?
Yes,
There is-
programming.
There are different other ways to do it. I know there are two at least. MIT, they have a free app developer. It's no code, maybe background code, but it's a simple way where you just, it's like building by blocks. So what you want to do is a box. You just put, I want a box. basically, and then what the content of that box. And it can read from Google Sheet. At the beginning, maybe it's kind of, you will need to learn just some of the basics, but it's similar to what Glide app is like. Glide app make it much easier. That's MIT. They want to make it easier, but they want you to build the not totally coding, but some code, but it's formulated in a block. The best example I can tell you, like if you look at the sand, if every little bit of it, this is what's coding. You need to identify the language where you want to put very details about things. In MIT, what they did, they collected whatever people are doing most of the time in blocks. An example, like if I want to build a house with bricks, I don't have to make the bricks from the sand. So the sand,
Yes,
someone put the bricks together for me. So your job is just how you can put the bricks in line and then stick them together. If that
so
makes
what
sense.
about the outcome? Is it going to be something good for the user?
So the outcome, that's the drawback is still, I use it a few years ago. This is why I went to Glide. At that time, they were not as fancy, the output, but you can replicate what you did in that way. The alternative for them, it's a similar concept with another company. I can submit you the name of that company, but they have the same concept, and you build the app with these blocks, like no coding, but just putting the blocks together. And it's the output, the layout and everything is fine-tuned, kind of similar to the Glide app, with the flexibility of doing things with Glide app. You are limited. It's fancy, it's very user friendly, but it's limited as far as the data. There is no interaction or building, like when you click on something, you want to wait and you want to display something, or the maneuvering is very limited in Glide app. But with this company, it's kind of, you are in control of things, kind of presented it better way. So I'll send you both MIT and this company and see which one. There are plenty of videos, YouTube, as far as how to build these things. And I use it in the past, and I developed my own app. Like now I can see I can just build it very fast if you have the concept. So you already have the app, so I don't think you will have trouble building it.
This is very interesting. Yes, I'm going to try this soon. I also read about other alternatives, like websites that can convert web apps into native apps, so they can be published into App Store or Google Play. But well, according to what I have read, they offer the same user experience. But they increase the accessibility to the app, so more people can see the application and download it. But I'm not sure if it's worth it or not, and I'm not sure if I should trust those websites. I don't know.
Yeah, I don't have experience. The only one I read about is the one you mentioned in the communication, that they can convert Glide app to both, and I don't know if we can trust them or not. I just read it in the discussion in Glide app, so maybe it needs a little bit of digging and see if it's true or not. If it's true, I think it's the best way. But if it's not, and then you don't have to go that route. I think we can build it using the MIT or the other company way.
Yes, I like the MIT idea. I think I'm going to try this.
Sounds good. Thank you.
Thank you so much.
Can be of help. Yeah, you're welcome. Good job. Thank you.
You're welcome, Dr. Nader. Thank you.
Assalamu alaikum, everyone. Salam.
Alaikum salam.
Thank you so much, Dr. Osama. I really appreciate it.
Yes.
How is Asa, by the way?
She's fine. Alhamdulillah.
Alhamdulillah. Say hi to her. Salam.